they're going to be very focused on one pathology. They're always going to be something. They will not give you, very unlikely they're going to give you something normal. So I'm going to give you 10 probable OSCE stations they might face. And the goal of this session is I'm not teaching you fundamentals for TAVI. The goal of this to prepare you to pass this OSCE exam. Okay. Mainly there's going to be case scenario, as you know. And if you need any further details about it, I'm not going to go into details a lot. I'm going to tell you what you need to know. And there's the theory stuff that you can look it up on yourself and try to memorize them. But if you have any questions, you can contact me later by email or phone. I'll be more than happy to do so. So I want you to understand there's two platforms for the transcatheter aortic valve that going to be brought to the OSCE station. Not the other ones. There's other ones coming, but they're already in the market, like the MyVal and Accurate Neo. But it is not important. What you're going to see, which is the most common and mainstream, are the two platforms. The self-expanding valve on the right and the balloon expandable valve on the left. Okay? And those are what they wanted to recognize on the OSCE station. Okay? You're going to have a station that's going to ask you, they're going to give you a scenario that to a patient with symptomatic severe aortic stenosis, and they will ask you to take a consent for the transcatheter aortic valve implant. So be systematic to do so. So Ayman, do you want it to be interactive or just go forward with it? What do you suggest?
I think it's better to be. It's only 1 hour, صح? It will be, صح?
Yeah, it will all finish earlier, inshallah.
Okay. Well, what you prefer, it's fine for me.
Okay. So let's start with any volunteer. I don't want to choose names.
Okay, I can start. My name is Dr. Anwar from National Guard, Riyadh.
Hayyak Allah Anwar. Yes, go ahead.
Okay, so we have to explain the procedure of TAVI to the patient in simple language. What is the procedure? What is the complications? And to answer the questions also. So, for taking a consent, we will explain the procedure also, that it is not the surgical. We will not open your chest. We will go through your leg side, through the good artery, and we will insert the catheter, and then we will insert the valve also. We will give something to sleep at that time for you with moderate sedation, called in our language, which you will not feel any pain or anything else, to decrease your anxiety also and pain also. As any other procedure, it has some complications also, which I will explain you in simple language. First, local, there be bleeding, mild, or sometimes, rarely it is more, can be in the abdomen or some other place, called as retoperitoneal hematoma, local complications. Sometimes, really, it can cause local complication to the entry side in the form of aneurysm or pseudoaneurysms, which are very rare. Then inside the heart also, rarely 1%, less than 1% can cause perforation to your heart, can cause fluid outside the heart, called in our language as pericardial effusion or pericardial tamponade. Sometimes your pulse can become irregular, your heartbeat, called arrhythmias, which we'll try to tackle this one. If you have any question, I will try to answer you these questions.
Excellent. Very good, Anwar. So, yes, so to remember it so you don't forget any domain, because they have a checklist on the...
Yes.
As you said, explain to the procedure. So one of the checklists is that you're going to consent not only for the transcatheter aortic valve implantation, also you're going to consent for a permanent pacemaker insertion. If needed. And also you can consent for an emergency cardiovascular surgery if the patient is a candidate.
Also transesophageal echocardiography also.
Yeah, so that's what I would do, and I would explain it the way you said. Okay.
Yes.
And then you talk about the indication for the consent.
Yeah.
So I'm doing this procedure. We're gonna fix the valve because you're becoming, you're having symptoms, or because your heart pumping is becoming weak, and you have a very tight valve, and the consensus that you're not a surgical candidate, or you prefer to do a transcatheter route, and that's why we're doing. So this is a checklist by itself, okay? And then the third checklist about the consent, as you mentioned, the complications, okay?
Yes.
Explaining the procedure in details is not required, but you can go over it. In consent, you should do it. Explain it in details, of course, but it is not required to mention in every detail about the complication. So the complications, for example, in the consent, so you say, I'm going to discuss with you the risk, the benefits, and the alternatives, and the risk that can include, but not limited to, bleeding, infection, contrast reaction, renal failure, vascular complication, arrhythmia, stroke, heart attack, emergent cardiovascular surgery, or death. Okay, so you bear it in general.
Yes.
Okay, so as you said, you did very well on one. You said, okay, if you have any questions, I'm here to listen for that. And that's in general the domains that are going to be checked. There's two things I want you to remember in addition to that. One, when you extend procedure, as you said, very simply, that we have to go through the groin. We're going to make you drowsy during the procedure. We're going to minimize the pain as much as possible. And when you say about the complications, is that they're going to ask you a follow-up question. They're going to ask you, is that what you're going to quote for the pacemaker insertion, permanent pacemaker percentage.
Yes.
So you get to be ready for that. Okay. So the way I would answer and say, okay, I would depend on if patient have a high risk features from the ECG prior. Okay. Two,
yes.
Depends on the platform I'm going to use. So that's what I would say in general. You don't have to commit to say. They might, some people are going to commit, okay, 1 in 5 or 1 in, do not jump to that. Say that. That's really going to make the examiners happy. They know what you're doing. Okay?
Okay. Thank you,
Any
sir.
questions about that? Okay, very good. It's just an example of that. So we'll go to the second question. I want you to think about it. What do you assess in vasculature for the TAVI? What are the things you want to assess? So think about it for a few minutes. Okay, who wants to answer this? Any volunteers?
السلام عليكم. مرحبا دكتور وليد.
حياك
عزيز تركي الله يحفظك. كيف الصحة؟
هلا وغلا والله اشتقنا لك يا رجل.
واحنا كذلك الله يحفظك.
الله يعافيك.
الله يعطيك الصحة والعافية.
الله يعافيك.
الله يحفظك.
تفضل يا عزيز.
So I'll assess for the vasculature. There are two kinds of vasculature that I'm interested in. It's the coronary, the aortic annulus, and the peripheral vascular vasculature. So I want to know, so for example, in the CT scan that we do prior to the TAVI. I want to know the common iliac artery size. I want to know the...
So this, okay. So size. Okay, one. What's the second thing? 3 domains. We want you to checklist.
I want to know if there's an aortic aneurysm or a dissection prior aortic dissection.
So that's part of the size.
Yeah. I want to know if there is a heavy calcification in the aorta, which increases the risk of stroke. And so I'm going to use an embolic protection device if that's the case.
I do not recommend to say that. Okay. Because there's no evidence. So don't go to details. We just want to know what you want to look for the vasculature.
I want to know the coronary takeoff, the coronary ostial takeoff. Is it more than a centimeter?
No, for the coronaries is different. Yeah, for the coronary is different. You're right. We can look at the coronary height. But for the vasculature, I mean, for the peripheral, all of it. So coronary different and vasculature is different.
Okay.
So for vasculature, 3 things I want you to remember. Okay, the caliber, the 3 C's. So you can see the caliber, which is the size, as you said. 2, the burden of calcium, like here. Okay. And curves, tortuosity. Those are 3 things. They don't want you to go to details, what sizes and everything. You're not going to be asked about these. But they want you to know what you should look for, because that's going to make you commit to transcatheter approach versus a surgical approach, correct? So those are the 3 things I want you to remember. Whenever they're going to ask you about what do you assess for TAVI, for vasculature, those are the 3 things you would ask for. Okay? Good. We'll go to the next one. So any volunteer, this is post-TAVI. Patient develop this. What you will do? We're going to have a crisis setting scenario.
Yeah, I can answer.
Sure, go ahead.
What I see now here, there is a femoral artery rupture.
Okay.
And first of all,
so you don't know to save yourself, because you don't know whether you're in the common femoral external iliac. So I would say there is a breach of the iliofemoral vasculature.
Okay.
On the left system.
Okay.
It looks like a perforation. They're going to give you scenario. Patient is hypotensive, 60/40. What will you do?
Yeah. First of all, should be stabilize the case first. ABC, airway, breathing, circulation. I will start from the maintain the blood pressure by inotropic support, by prepare for ask for blood and for possible mechanical support as well. And I will call for I will consult the vascular surgery.
Excellent. So that's important. Call for help. So ABCs. Call for help. Say if I can do any endovascular tamponade to that perforation. Get venous access, large bore for emergent blood transfusion. That's enough. Okay. So the ABCs, the checklist we're going to say for the ABCs, and then endovascular intervention, vascular surgery, contact. Okay. And then you reassess and the blood transfusion. Okay?
Okay.
Very good. Okay, I'll give you the second scenario. I want you to look at this. This is TAVI trying to implant the valve. This is a self-expanding valve. You can see the guide wire is deep in the LV. Okay? And then the valve was deployed. Okay? The patient start to be hypotensive, and the patient become severely bradycardic, and you can see here there is double shadow of the heart border. Okay? You do a bedside echo emergently, you resuscitate, you see this. Okay? The question they're going to ask you, what are the causes? They will not say the cardiac tamponade, they can see tamponade, but what are the causes of cardiac tamponade post-TAVI? Any volunteers?
I can take it, Doctor.
تفضل.
So the first called annual rupture of the aortic valve.
Okay.
The second cause when I use the step wire, maybe perforation of the LV.
Okay. Anything else?
And plus wire and rupture.
Okay.
Well, that's it.
Okay. So this is a scenario very likely might come. Okay. So I want you to remember it's more common in women. Okay. And the causes are three things. I want you to remember, as Dr. Imad alluded. The most common is RV perforation by the temporary pacemaker you put in, about a half. Second, it goes to annual rupture or dissection, about quarter. Third, any tear within the LV free wall caused by the stiff guide wire. Okay? So those are the three causes. Just remember those three. Okay? What are the risk factors for annular rupture? So remember, where's the device going to landing zone? Okay, anatomy, okay, degree of calcification, and degree of how you size the valve if you're oversizing. So remember those three things, okay? The degree of calcification, the degree of valve oversizing, and the anatomy of the sinus. So you look at sinus of valsava, if you have the anatomy of the cusp, anatomy of the annulus, anatomy of the LVOT. So you go anatomical from the LVOT, annulus, cusp, sinus. So you don't forget. Based on that, that's where the risk of annular rupture. Okay? So I just wanted to remember those headlines because this is how the examiner is going to checklist. You don't want to go a lot of details. Try to be very, your brain is filled with a lot of information, and you need to be really minimized and to cover all the checklists they have. Okay? Next question. You have a station that they show you a post-balloon expandable TAVI, and then they show you this. Okay. I want you to think about it. Any volunteer? What do they see? What is this? Okay, this is an LE view showing the LV, and this is going through the septum. Okay, and this is echo showing a iatrogenic VSD post-TAVI. Okay? So that's a scenario they might face, okay? Okay, next scenario. What are the risk factors for this complication?
Valve migration.
Excellent. Okay, so there's valve migration. To save yourself, better than embolization, say migration, because migration can go both sides, okay?
Yeah.
So good. The reason you see the pacemaker here is not really, they have a PVC, and that's what the valve make it move. Okay, very good, excellent. So the risk factors for that is that you didn't have proper pacing. In a balloon expandable valve, you have to pace very well. The reason for rapid pacing in balloon expandable valve is that you want to reach the pulse pressure very low. So there is no, the valve doesn't move. But in this case, because there was PVC and it was not really capturing well, that happened, okay? But luckily it was pushed back. Okay.
دكتور وليد هل ممكن أقول one of the risk factor for migration in eccentric calcification or inadequate calcium or مثلا aneurysm or oversized large size aorta?
I would not say that.
Okay.
So because of improper sizing, but go with the common, because here you can see the always the balloon expandable issue is this. Other stuff is technical. They don't want you to go through that because they anticipate that everything is done properly, right? So,
okay.
So in technical stuff, they don't want to go over it.
Okay.
Okay, show you this. What is the contraindication for surgical aortic valve replacement in this fluoroscopy? Any volunteers?
Coronary height is low for the.
Okay. Any other volunteer?
Is it?
So good. You said that. Never say coronary height assessment based on an aortogram.
CT.
Borderline.
Never. Yeah, CT. Never do that in the exam. So good. You said that. So all the staff, everyone knows that. Not to be said.
Okay.
Okay, good. So what do you see here?
Porcelain.
Excellent. So this is a very calcified porcelain aorta. So this is a contraindication for surgical aortic valve replacement. Very simple. They're going to ask you these things. They're going to give you a long scenario, and then they're going to give you a series of questions, including that. Another case. Describe the complication.
High seated valve.
Paravalvular leak.
Yeah.
Okay. Both of you are right. Okay. The way you see it, didn't say high seated, say high implantation. Okay. So high implantation into the aortic of the valve cause a severe paravalvular leak. You're right. See the paravalvular leak and see where the valve is. It's above the annulus. Okay. This is a very frequent scenario. They might ask you. Okay. Post-TAVI, after removal of the sheath, you find this. Describe the finding and how you're going to manage it.
It's an peripheral vascular perforation. And the management is ABCs, transfusion of blood, tamponade the site, and call for help, and if appropriate, put a covered stent.
Excellent. Very good. So that's exactly what they want you to, because they have a checklist, you have to go through it. Even if you talk in details about one, like an expert, it will not count the other stuff. So well done on these. ABCs, okay? You go to the hemodynamics, get the immediately get the blood, and try to manually control the source of bleeding, compress, because this is easy, it can be compressed over the pubic bone. Control by compressing, and then call for help, vascular surgery. Most people do it without, the interventions can deal with it, but for you, just for the exam's sake, if you say that, that's okay. So, and then you say endovascular intervention, if warranted, as don't mention about the details about the stent, because there's a lot of technical things. So just be vague. كأنك في المحكمة. Say what is needed. Okay, excellent. Okay, a scenario, they're going to give you a scenario in a station, and they will ask you what are the indications for TAVI. So this is thing you didn't need, I don't want you to ask you now. You can go over it at home. I think pretty sure you can memorize the indications, which is equivalent to the surgical aortic valve implantation. Okay? But make it very easy. You mention it like fast, without trying to recall them. Okay. Last question. Station that I can ask you, they give you a scenario and echo findings, and then they will ask you about the indices for severe aortic stenosis. I want you to remember the severe aortic stenosis. I want you to remember indices for low flow, low gradient AS, okay, and paradoxical low flow AS. So I want you to remember those three indices because they're going to ask you in one of the stations. Okay, so that's all. I hope that's going to help you. Very crash course before you embark, inshallah, في الأسبوع الجاي. And I'm confident, inshallah, بإذن الله وحده, you're going to all pass بإذن الله.
بإذن الله يا دكتور يعطيك العافية جزاك الله خير. وعندي بس one question and we face it a lot صراحة في about the contraindication of the TAVI. They mentioned bypass and it's sophisticated answer sometimes bypass and severe AI. هل نذكرها في
No, that's why I didn't mention it here. ممتاز كويس. I didn't mention it here. The reason you might get it in theory, but in the OSCE they don't want to mention it because it's a gray zone. The scientific committee, they made a decision that we should not bring things that are gray zone because we do bicuspid, as you know, and there is data to support that. So we don't want to mention. We don't want to mention things about sizes because there is a gray zone that we're gonna that you have to deal with.
And even low AF, they mentioned less than 20%. Is it correct? This one or?
Yes, it is mentioned, but it is. We don't want to mention. We don't want to bring it because it's. As I told you, it's a gray zone, and you know that. I mean, we've done cases with those low ejection fraction. We want things that want you to be a competent and safe cardiologist, not to test your expertise.
Okay. يعطيك العافية دكتور وليد.
الله يعافيك ويوفقك جميعا.
معلش one question بس. Regarding porcine aorta, you bring it as contraindication for TAVI.
No, not for TAVI. Not for TAVI.
Okay. For surgery. Still, we can do it with porcine aorta. TAVI.
Yeah, TAVI is it's actually, this is one of the prohibitive because one of the things that you cannot do it in surgery is the porcine aorta, which is not in the STS score. like liver cirrhosis and other stuff.
اوكي ثانك يو
اوكي الله يوفقكم جميعا ان شاء الله.
السلام عليكم دكتور، معلش لو سمحت سؤال.
السلام ورحمه الله.
بالنسبه لما السيشن بتاعت الكونسنت if they ask me to take consent for TAVI, should I assume that the patient already knows his diagnosis and he knows that he's going to have a procedure, or I need to explain from the start? I will check his understanding for the diagnosis, the aortic stenosis, and then
the stem, based on the stem. Yeah, based on the stem, what is mentioned in the stem. If the stem tell you the patient aware and he's going, explain to them and going for the transcatheter aortic valve, as I told you, remember the domains, each one. And what is the indication? We're doing this procedure, this kind of procedure because you have this and this and this. You have to mention it. And then mention the procedure. What are the procedures you're going to do? And explain it in very brief. Don't go to details because you have no time. And then you go to the risk and benefits, which include the complications in general. And then ask the questions the patient has any. This is important to ask them at the end if you have any questions I need to answer.
Okay, thank you.
Okay. يلا بالتوفيق جميعا. الله يحفظكم.
جزاك الله خير.
جزاك الله خير.
مع السلامة.